live? Lovely. So very good evening to all of you, or very good morning to some of you, and a very warm welcome. My name is Pascual Daza. I'm a working GP in the southwest of England, and I'll be your host for today's webinar. I'm delighted to present to you a really very experienced panel, which you have on the screen. Let me just give you a little bit of housekeeping information. We are going to run the webinar in a way such as all the presentations are pre-recorded, so we're going to let the recordings be presented to you, and that will take 5 minutes each presentation, all in succession. It will take around 20-25 minutes. If you have any questions, you can post them by joining the WhatsApp group that you've got on the screen. That will facilitate the running of the presentation in a way that I don't have to look at the chat myself. And the question then will be posted to the panel. I hope that is acceptable to you. There are two main objectives for this meeting, really. One is to have a brief overview of the scientific evidence supporting the use of point-of-care ultrasound in general practice. But equally important is to explore the merits of this imaging technique. And we would like, through the panel and the presentations, explore this diverse range of perspectives. So I'm really excited and thankful to the panelists and experts that are here with us today. Let me start by introducing Dr. Bjarte Sorensen, who today will share with you the key findings of his systematic review and meta-analysis published in 2019. He also will explain the clinical applications of POCUS in general practice in his current job in rural and remote areas of Australia. Although he's a native from Norway, he's an adopted Australian, and you will detect by his accent that he's almost more Australian than he's Norwegian these days. I've got the pleasure also to introduce to you Camilla Andersen, who is joining us from Denmark, and she is very kind to have given us her time today to summarize the outcomes of her extensive research in POCUS. Especially, she will be presenting the key findings from a single blind randomized controlled trial, and also what the surveys of patients' experience is when receiving point-of-care ultrasonography. And she will present to us some of the challenges when it comes to training general practitioners in this imaging technique. Also, I'm delighted to have Hazel Edwards with us, who represents the British Medical Ultrasound Society, and she will provide us with an overview of how the society has been working in the UK, training and educating clinicians, and what the efforts are made these days to actually help general practitioners to develop this skill. A special thank you also to my fellow colleague and GP in the UK, Lee Persgrove, who is an innovator and one of the leaders in the UK in adopting point-of-care ultrasonography in general practice. And he's going to give us a very eloquent explanation as to how he makes this happen in real life in the UK, given the constraints that all of us have. Finally, but not least, is my colleague, Dr. Parkinson, who is a GP trainee in the southwest of England, who we've had the pleasure of working in the past. And she's going to actually share with you the key issues that trainees face in learning a new skill such as this. And also she will present to you the results of a recent survey amongst junior doctors in the UK. At this point, I'd like to actually extend again my gratitude to every one of the panelists, my colleagues from the Global Ultrasound Institute, Elizabeth in the background making this happen, and all of you for being present here today and having an interest in this area. So I'm going to run the presentations in succession. I hope you enjoy them, and then we can actually start debating and posing questions to the panel. And thank you very much for being here today. I started my point-of-care ultrasound journey in 2006. soon after the launch of GE first handheld device for echocardiography. Since then, the clinical applications and versatility of the ultrasound devices have expanded dramatically, making this imaging modality a tangible and affordable diagnostic tool for general practitioners at the bedside. I would like to set the scene for today's webinar by sharing a few thoughts with you. Samir Kasha, with whom I had the pleasure of working in the past, described the concepts of scientific explanation and causality. Philosophers think the link between these concepts is quite intimate. Explanation and causality are at the center of the patient-doctor relationship. Patients expect to gain an explanation about their medical concern. Doctors hope to find the cause of the patient's problem. Michael Balint and Richard Neighbor were instrumental in the reformulation of family medicine as an important aspect of medical care in the NHS in the UK. General practice in the late 60s and early 70s became an academic discipline, gaining reputation within the medical hierarchy. The irony is that general practice has become a general specialism. Point-of-care ultrasound offers a better chance for GPs to explain the cause of a given medical problem at the bedside. Let me share an example with you.
I thought I might try and find another clock to work on to get us through this.
I don't need another clock.
Clinical decision-making is a complex process determined by cognitive and affective components. So NHS leaders might ask, what are the benefits of point-of-care ultrasound? What are the implications in practice? So it is my pleasure to invite you to explore these questions and much more with our panel of experts.
Hello there, I'm Dr. Beata Sorensen, recording from Australia. I have to minimize myself now, which is a bit difficult for me to do. Now I manage, there you go. And I have to talk about this in 5 minutes. It's almost more impossible task than minimizing myself. But anyway, here we go. I'm a specialist in general practice in Norway. I studied in Sydney, Australia, and I also specialize in general practice in Australia after I've been in Norway for 15 years. And I'm currently here as a fellow of the Royal Australian College of General Practitioners. I'm going to talk about a study me and Steinar Hundskog at the University of Bergen did together, a systematic review article on the generalist performed point-of-care ultrasound in unselected populations. I'm going to get back to the exact meaning of that title, but anyway, here I am. I'm in Norway, on call, about to go out with the ambulance boat to a patient. And this is back in 2018, I think, the butterfly has just come out. Several other handheld ultrasound machines have come out since, and I'm not paid by anyone. There's another ambulance boat that I worked on there, and we covered about 100 by 50 kilometers of islands with sparsely populated. However, the amount of rain there is miserable. It's about 200 days of rain, and the winters are dark and long and cold. And my heart was still in Australia after having studied there since I was 20. So I moved back with my family, and we are very happy about that. 200 sunny days. And this is the mode of transfer of patients generally from the areas where I work, because I work in South Australia, in rural and remote areas generally. I work about 2 weeks on, 2 weeks off roster, and living in Adelaide with my family when I'm not at work. But when I'm at work, I could work in places like Coober Pedy in the middle of map here, which is about 1,000 kilometers from Adelaide, same with Ceduna or the Eyre Peninsula. And just to give a bit of perspective, this is a map of the UK, transposed on top of South Australia. And when I'm calling Ceduna, for instance, the area that hospital covers, which I'm the only doctor of, is bigger than Scotland and the island of Ireland combined. We have about 900 kilometers to the next doctor, which is in Adelaide, tertiary hospitals. So you can imagine the use of ultrasound in my hands, if I'm capable and can do it adequately, would be very useful, wouldn't it? So I always wondered, is it good enough? I always had the question, probably it was question myself more than my colleagues did. But can I actually do this? Is it useful? Is it beneficial for the patient? So I went ahead and did this systematic review, and where we looked at not just general practitioners, but also emergency medicine physicians, because they're also generalists. They work in unselected populations. And we found 370 articles, out of which 157 had already been included by meta-analyses that we included, 26 of them, and could push all this information into one big article, lots of tables and numbers, which you can look up if you're interested. I think it's quite useful for you to do, because you understand a little bit more about the breadth of what we can do. And I would like you to look into likelihood and positive and negative likelihood ratios rather than positive and negative predictive evidence, because the latter are a bit dependent on knowing the population prevalence in your particular population, whereas likelihood ratio just you only need to know something about the pre-test probability, which we are generally very good at in as GPs. May not necessarily be exactly the same as the incidence of the general population of the country, but you know roughly in your particular population what the pre-test probability of any diagnosis is. By knowing that, and by knowing the positive likelihood or negative likelihood ratio of a certain finding, you can say something more about the post-test probability by using, for instance, Paget's nomogram like this one. I'm not saying you're going to have to use that necessarily clinically, but it's good to have an idea of what you're actually doing by doing a test. Like any other test you do, any question you do, any examination you do, or any blood test you do, you should have an idea of what that sort of does to your diagnosis probability. But we found articles that did accuracy studies on, we're not talking about case here, these are generally accuracy studies, often prospective, on all these domains: heart, lungs, vascular, cerebrospinal, soft tissue, musculoskeletal. I don't think I have time to mention them all, but really, it's really quite useful. I've probably used all of these in my clinical experience. I don't expect any novice to know them all at once, but I think it's useful to pick a few that you find interesting and that sort of would be useful in your particular work experience. And I certainly have helped, I think, many patients by finding the diagnosis quicker, and by not, for instance, doing a digital rectal examination on a child where I'm expecting constipation. I can actually measure that rectum diameter. There's studies on that. There's studies on so many things. Pregnancies, of course, gestational age, showing, for instance, that we are non-inferior to obstetricians when it comes to gestational age. Ectopic pregnancies, threatened abortion, fetal die, abscess versus cellulitis, foreign bodies, less dramatic things like nail bed injuries, quite useful. Peritonsil abscess, I found it. They weren't clinically that apparent, but I found it, and they were very significant for that particular patient. Retinal detachment, amazing. Fractures, you wouldn't believe it, but it's actually more accurate than X-rays for many of the fractures we're talking about. This is pulmonary edema, this is pneumothorax, this is my father's abdominal ascites when you have pancreatic cancer. Well, it's quite useful because we were taking some of that out every day. This is my rib fracture, where I wanted some more empathy from my wife, which I didn't get, but at least I could prove it was broken. Lots of uses. I think it's really up to you to start using the evidence and go ahead and learn about the evidence, because you're going to be asked, is this safe? And the answer is generally yes. In trained hands it is, and you can be trained. So in general, it shows that generalists can, given a certain level of pre-test probability, safely use ultrasound and diagnose patients with it. Often it shows a high sensitivity for a certain modality, and that will obviously help us rule out the condition. Whereas other times, it shows the study showed a really high specificity for a certain condition, which means that we're going to rule in condition. And often it showed both. So it can actually be useful, say, in a screening setting, let's say for abdominal aortic aneurysms. I'm not going to talk about screening, obviously, but it's as good as any other screening tools that we have today in generalist hands. So, and it's even better than X-rays in blood settings. Pneumonia, certain fractures, pneumothorax, it's better than X-ray in generalist hands. I urge you to go and look those things up, actually learn about the evidence that's there, and go to courses and teach yourself. Good luck.
Point-of-care ultrasound has been introduced as the stethoscope of the future. It is a powerful tool in the hands of the clinician. It has been found to reduce time to diagnosis in hospitalized patients, where it has been found to be superior to standard care physical examination and other diagnostic tests in terms of reaching the correct diagnosis early. In primary care, it has also been found to have a large influence on patient management. A prospective cohort study from Denmark revealed that point-of-care ultrasound use resulted in a change in management of patients in 72% of consultations. And the patients love it. They feel they receive a better service and a better quality of care in primary care when offered point-of-care ultrasound. And there are potential cost savings by introducing point-of-care ultrasound in primary care as a result of more precise diagnosis in the front line and less referrals to secondary care. Point-of-care ultrasound has been introduced in primary care across Europe. In 2016, there was a large variation in access to in-house ultrasound across countries. But recent studies from Norway, Switzerland, and Denmark show a rapid increase in the use of ultrasound by general practitioners. And the World Family Doctors Organization and the European Ultrasound Society now supports and advocates for the use of point-of-care ultrasound in primary care. However, there are 4 unique training challenges that GPs face when they strive to obtain scanning competencies. First, the short consultations in general practice leaves little room for practicing skills. Second, GPs often work alone, and that challenges their opportunities to have supervised scans by more experienced colleagues and feedback on performance while scanning patients. Third, the low frequency of ultrasound use in general practice challenges the GP's opportunities to develop routine and maintain scanning competence over time. And fourth, the low pre-test probability of disease in primary care challenges the GP's exposure to pathology and thereby their ability to learn to recognize pathology. We know that developing and maintaining scanning competence is an ongoing process where GPs continuously train and gradually add more knowledge and more application to their individual portfolio. A systematic review from 2020 evaluated ultrasound training programs for GPs and found that both theoretical and practical training was important. Scanning competence increased with longitudinal training and continuous feedback on performance. We know that harms are related to GPs performing too advanced ultrasound examinations or explorative examinations without a clear, predefined purpose. Therefore, it is important to offer high-quality training programs for GPs. Training programs that account for the training challenges that office-based GPs face, and that includes a curriculum of focused point-of-care applications that will improve the care of patients in primary care, that are manageable in terms of learning to perform the examinations during the training program, that has a high diagnostic accuracy in the hands of generalists, and that are frequently encountered in daily routines. Luckily, we have evidence that this is feasible, and I look forward to discussing this with you today on this webinar. Thank you very much for listening.
Hello, I'm Hazel Edwards, the Professional Officer for the British Medical Ultrasound Society, BMUS. I'll be talking about how we can support GPs using POCUS. So a little bit more about us as a society. We are a multidisciplinary society. We have been around for 55 years now. When we first started out, ultrasound machines looked like this. They filled a whole room, and skeptics said that the imaging modality would never catch on. The rest is history. We have four main aims: the advancement of science and technology within the field of medical ultrasound, the maintenance of the highest standards in this field, the advancement of research and education within ultrasound, and we also provide advice and information to the public. We comprise a number of special interest groups, and we have around 1,700 members. So how can we support GPs using ultrasound? Well, if you think about some of our healthcare priorities today, they include earlier diagnosis, to expedite safe and effective patient care, to avoid unnecessary hospital attendances. And we know that with the right support and training, GPs can help in all of these areas. But they have a number of barriers to overcome first, things like time, money, education, supervision, and there's a lack of clinical guidelines for them at the moment. And BMUS can help with some of these issues. And certainly we support all POCUS users, not just GPs, if they are using ultrasound in an attempt to answer a clinical question. What we don't support is the use of ultrasound for entertainment. On our website, we have a number of open access guidelines. We have our very well respected safety guidelines published in 2009, but still used internationally. We have our guidelines for professional ultrasound practice. In this, there's lots of information on nationally recognised management pathways, tips on report writing, and do's and don'ts when it comes to saving images. And last year, we published a joint document with the Royal College of Radiologists, and this gives lots of information to POCUS users when it comes to safety, governance, equipment maintenance, and education. It also includes information on what radiology department should be doing for you as well, if you reach out to them asking for help. We offer lots of education too. Some of it is free, some of it is member only. On our website, we have lots of interesting cases with plenty of ultrasound images for you to test your knowledge on. We have scanning tips from experts, and we have over 50 webinars in our webinar library on all sorts of topics. We have our quarterly scientific peer-reviewed journal, Ultrasound, and we hold a number of face-to-face study days and scientific meetings each year. We can help with networking and collaboration. For our 3-day meeting in Coventry this December, we have dedicated POCUS sessions already lined up, and indeed we have them every year. We have good links with universities who offer postgraduate POCUS courses. We have links with academies, ultrasound experts, and all the main manufacturers. Plus, we work closely with EFSAM and WFUM. EFSAM is the European Federation of Societies in Ultrasound in Medicine and Biology, and WFUM is the World Federation. And because we're a partner organisation, anyone who is a member of BMUS automatically becomes a member of EFSAM and WFUM. And finally, we can help with research and development. If you have a project in mind and if you want to get it kick-started, so long as it aligns with our aims and our values and ethos, there's every chance that you might be awarded one of our research and innovation grants to help you get going. So thanks very much for listening. If you don't want to ask questions now, you can email me on this address and I'll get back to you.
But now that we
Apologies, I'm having technical problems. I'm trying to solve them. Bear with me. Sorry, Lee. I'm trying to get this right. I knew it will be a glitch at some point. Elizabeth, I don't know what to do next. I apologize. See what I can play here.
But
Well, I could try projecting. Is this the last presentation? Or is there...
No, there is another one. It's just the first slide for some reason. If I go back for a second.
good evening, all. My name is Dr. Lee Perscliffe. I'm a GP working in the Northeast, and I've been very kindly asked to show you how point-of-care ultrasound can work during a GP consultation. I am part of a wider GP group called Primary Care POCUS that have a pure interest in adoption of ultrasound technology in primary care. But before understanding how POCUS can work in primary care, we need to define our remit of practice. This way, the whole medical fraternity can understand what we're trying to do in general practice. Now, the GP has the widest curriculum out of any speciality, and thus point-of-care ultrasound at the bedside has huge potential. And what we fit in is hotly contested. And ultimately, what can be taught is dependent upon your interests, your skill level, what device you have, and also the needs of the population. But ultimately, to encompass all of that, I say that the POCUS mandate is any ultrasound scan that answers a yes or no question or gives a definitive answer within 5 minutes should be doable within a GP consultation. Now that we know what the remit of practice is, why do it in the first place? Well, here are 10 good reasons why a GP would pick up a probe in a consultation. Naturally, we all know that the history and exam is not enough on its own to make a diagnosis, so we use the ultrasound to help with that issue. We do a lot of scanning to reassure people. It's very easy to point to the picture and say, look, this is what it shows, and patients are very reassured. We can also rule out complications, for example, a failed catheter placement or spontaneous expulsion of a coil or bleeding post-surgery. We can also use it to plan minor surgery and guide ultrasound injections. And we can use it to predict the future. For example, tracking malignant infusions in the chest or lumps in the neck, which can be reactive before someone gets unwell. It's a fantastic learning and education tool, and it gives back just as much as you put into it. It's fantastically enjoyable, and I love doing it, so there's no biases there. It can reduce the burden on radiology departments, and I will talk to you about that at the end of this. I have proven to myself that it can be safe, and also it's the only modality that provides a dynamic assessment there and then. Now that we've defined the remit and why to use point-of-care ultrasound in primary care, how do we integrate it? Well, this is what a general room looks like. This is my office in ours, and as you can see, there is a handheld device here, which is quite small. It's wireless, and there's a cart-based device here, which is a little bit larger. And my patients sit here. So whenever there's an issue and I feel there's a question that can be answered, I simply boot the device up, which takes seconds, and do the scan. As part of the wider practice, your colleagues will need to know how you are integrating this into your appointment ledger. And here is a typical appointment ledger for System 1. And I would recommend that your point of care scan goes either at the end of a session in the morning or the afternoon, or form part of a fellowship where you get dedicated time slots for a little bit longer, where you can have the space and time to practice, or before a break slot. You can speed things up by using templates with System 1, and generally speaking, if you are unsure with your ultrasound scan, you would always treat as you would as a normal GP, ignoring the scan. And finally, putting it all together, this is a service evaluation that I did of my own work over 19 months, which included 339 GP scans. Now, I'm happy to share this data with anybody, and I'm hoping that this data can demonstrate to you the health economic benefit of using ultrasound at the bedside in primary care. My data showed that 242 referrals to radiology were avoided, and that 71 referrals to radiology were made in addition to GP POCUS scans. And 6 admissions were directly avoided, and there were only 3 total episodes of potential harm to patients, but these were low acuity. And I hope you as policymakers can understand the benefit of POCUS, and I would be more than happy to make connections and support you with any questions that you may have. Thank you.
Hi, my name is Dr. Molly Parkinson. I'm one of the GP trainees down in Tor Bay in the southwest, and I'm going to be talking about point of care ultrasound from the trainee perspective. So how did I get involved with this? I was invited by Pascal to participate in an educational project to provide trainees with skills in POCUS in collaboration with the Global Ultrasound Institute. He sold me on the clinical benefits of the skills, so I thought it would be a good thing to get involved with. So I assisted in the organisation of a weekend beginners course for trainees in the southwest, and also attended that course myself. And I have ongoing involvement with this project. We've now done 2 iterations of that specific course that I've been involved with, and I think there have been others as well. And ultimately, I hope to consolidate my skills through future courses and in the workplace, and then eventually tutor on the course. So benefits of learning POCUS as a trainee from my perspective. So it's relevant to loads of different specialties. So pretty much whatever you're training in, it will have some relevance. There's more time to learn an extra skill, arguably, in the early years of training, as opposed to when you're a registrar and you get engulfed by exams and portfolio. You can add an extra skill to your team, and that really increases job satisfaction because you feel like you're contributing. Obviously, this is in the context of using POCUS as an adjunct and not in place of formal imaging. And it also contributes, if junior doctors are learning this, it contributes to integrating the skill into the NHS, because to truly integrate it, you need to train from the bottom upwards. And to show that other junior doctors see benefits in this too, here are some of the post-course survey results from the courses we ran in July and October of last year. So the vast majority of trainees agreed that ultrasound at the bedside enables faster and more accurate diagnosis for patients. Again, all of them were interested in improving their point of care ultrasound skills, and the vast majority agreed that all junior doctors should be trained in point of care ultrasound. So it just shows there is an appetite for this amongst the junior doctor body. So then why is it not happening? Why is it difficult for junior doctors to get involved? So some of the drawbacks or issues, the main one is that there's a lack of opportunity to consolidate skills. So it's quite easy to go on the course, but then in order to become truly proficient, we all know you have to consolidate the skills. I know colleagues who have had pushback from seniors within their department who themselves aren't trained in the skill, so they feel they can't supervise their juniors doing it. There's often lack of time in the clinical environment due to the requirement for service provision. So it's easy to think, well, what's the point in me spending 20 minutes scanning them if I'm going to have to send them for a formal scan anyway? And obviously it'd be a really good educational opportunity and important for consolidating skills. But when you're under time pressure in the clinical environment, that unfortunately, as most of us will know, isn't a priority. There's also a lack of trained seniors in general to supervise and give feedback, so it's hard to develop the skill further. There's a lot of red tape, so some trusts and heads of department will argue that you need to have done an accredited course to be allowed to practice the skill in the clinical setting. There's a significant lack of these accredited courses. And such courses are also often very expensive for trainees and not funded by training deaneries because the skill isn't currently integrated into practice in the UK. So therefore you get a vicious cycle where there's a lack of opportunity to get trained, so the skill doesn't get adopted as mainstream, and then therefore there's a lack of opportunities to get trained. The current NHS climate overall also just makes it very difficult to drive change, even though integrating the skill would have so many benefits in the long term. I think just the clinical pressures make that quite difficult at the moment. So solutions, I don't have the magic answers, but some things that I've thought about would be, should we be trying to integrate POCUS into the undergraduate medical curriculum to truly train from the bottom up? You could argue there's enough for undergraduates to learn already, and what do you take out in order to integrate this? Ideally, we should be making the training more affordable and accessible, and things like remote supervision of scanning via the cloud, which Global Ultrasound Institute have been involved with, can be really, really useful because it means you don't need a supervisor at your place of work. You can just have your scans reviewed and feedback given via the cloud remotely. We could potentially train more middle grades so that more seniors are able to carry out training courses and supervise junior trainees. So maybe we need a wider mix of grades attending these courses, trying to appeal to more people. And then you could argue that in order to truly integrate the skill into the UK practice, we'll need to change the culture of the NHS, but that is a talk for another day. So thank you very much. That's the end of my talk, and I'm here if you have any questions. Thank you very much.
So thank you all. If you want to post some questions on the WhatsApp group, please access through the QR code that you got in front of you on the screen. I've got several questions here that people have posted on the WhatsApp already. As you can see, we covered a whole range of issues and points that are relating to point-of-care ultrasonography from the perspective of those that practice it with a great deal of competence in the acute setting, for those that practice in the context of a normal general consultation in the UK, for those that practice as a trainees and learning the skill as we speak. So I'd like to ask whether any of the panelists would like to make any final remarks on the presentation first, and then we will open the floor to everyone to ask questions. How about if I invite Hazel to make some comments on how the British Medical Ultrasound Society will envisage the future to promote training and education beyond what we are doing today. Would that be okay, Hazel?
Yeah, thank you. And as general comments on the presentations, I thought they all fitted together really well, and I like the way that people were saying the same things about not practicing outside your scope and how ultrasound is safe but only in trained hands and so on. So certainly we echo all those thoughts and opinions at BMIS, and we are very happy to support the growing GP POCUS community. As I said in my presentation, we've got a number of things on offer already, like educational initiatives, ultrasound images and so on, guidance, because I believe strongly that you still need to follow guidance, even if you are using ultrasound in a limited capacity in your surgery, more than ever, in a way, to ensure that you and your patients stay safe. But we know that the big thing for GPs is getting some hands-on training, and that's one of the biggest obstacles to overcome. And BMIS is very experienced at hosting study days. We are able to provide live models to scan. They tend to be our student members who volunteer to be scanned, and in return they get the education for free, so they benefit too. We would be happy to either work with Molly to support her course, or to link up with Lee and his group, or to develop a bespoke ultrasound course for GPs if we know the demand is out there, and if people reach out to us, and we know the interest is growing, and if we have the right numbers, we can provide the courses with the expert faculty.
Thank you, Hazel. Thank you very much. I just got a note here from one of our colleagues to say, and you probably can see it on the WhatsApp group, to say that this is Rachel Mannings, to support Molly's slide on backs and issues unreflected and the views of trainees. Molly, would you like to comment on how generalizable the results of the survey that was carried out in 2023 is of what junior doctors feel with regard to POCUS?
Yeah, so I think it's difficult to tell exactly how the junior doctor body feels, because the group who attended the course is sort of a self-selecting group who were already interested. So naturally their survey results are going to be quite positive about the skill in general. But I do think when I've spoken to lots of colleagues about it, and I think there's always a lot of interest. It's just about the practicalities of how and money and how to fit it in amongst everything else, and also like being, it feels like you're sort of not allowed to integrate the skill into your practice because there's a lot of skepticism from seniors, and so it's all, yeah, so I think lots of people are interested, but they don't necessarily have the time or the headspace to work through the logistical difficulties of getting it done. So they all acknowledge that it would be a good skill ideally to have, but it's just so much else going on.
Thank you, Molly. Bjarte, can I ask you to step in and tell us what's happening in your experience in Australia with training, particularly when you have the responsibility of covering such a vast area in where you practice, as well as what happening in normal day-to-day general practice in Australia?
Yeah, sure. I have only been in the Australian GP environment lately for the last 12 months, working hard. So I've had little time to see what's going on in the ultrasound world, in GP world here, in the GP environment here, but a little bit. I think there are no rebates for GP-initiated ultrasound scans here, which means financially it's not really viable for a lot of places, therefore they don't use it. I think you find country doctors more likely to use it because they're often connected to a local hospital where they are the only doctors also working in the emergency department, where there often are ultrasound equipment. So if it's sitting around and it's free to use, then of course you will get interested in learning how to use it for the benefit of your patients. So to get the perspectives, right now I'm in a town where the nearest hospital is about 150 kilometers away, and any imaging I can do that is relevant and safe and useful for the patient will obviously save the patient for traveling 300 kilometers. So I went to a course in Alice Springs on a point of care echocardiography, which was really useful. And I found other rural generalists, general practitioners there, which also really found it useful. For instance, in the Aboriginal population, where rheumatic heart disease is still actually a thing. In certain populations, we treat every sore throat with antibiotics because the pre-test probability of rheumatic heart disease is really high, actually, believe it or not. And you having ultrasound to be able to look at that is really useful for them, and you can pick up people with heart problems quite early. So what I'm saying, I suppose, is we're such a diverse community across the world. We're such a diverse specialty as well. I think everyone needs to look around themselves and what's useful for me and how can I use this. Yeah, now there are many hurdles to get there for many people, I think. Yep, definitely. Money is probably one of the big things we don't often talk about.
Yeah, thank you, Beate. Lee, can I approach you in? Picking up on what Molly was saying regarding training, access to training, and also Hazel and affordability. What are your key thoughts on how the NHS and GP land in the UK? What are the key factors there, in your opinion, that one should be looking at and present to the decision makers and budget holders?
Yeah, it's absolutely. You can hear me okay, Pasquale, and the rest?
Yeah.
Yep. Okay. Yeah, it's absolutely the right question to be asking. Following on from what Beate's just said there, I think trying to introduce some of the funding that secondary care get from radiology departments, if we can bring some of that into primary care, then that would be huge. But we know from history that that is incredibly difficult to do. But I've certainly been working with some of the manufacturers who obviously have interests in selling devices, and I believe that this journey needs their input, and to get it off the ground. And thankfully, they've got infinitely more resources and financial backing than the single GP. And I think in collaboration with them, and the research and evidence and educators, we can make a very, very strong argument for bringing some of that funding into primary care. I hope my service evaluation and Camilla's research shows quite clearly that there are health economic benefits to be made from picking up issues early, treating early, and avoiding hospital input altogether. So that's a work in progress. I think also as well, if we could get point of care ultrasound into, sorry, just a second.
Thank you, Lee.
Yeah, sorry. So, just following on from that thought, if we could get point of care ultrasound somewhere in the NICE guidance as part of pathways for certain for certain illnesses like DVT pathway, then that would be huge. That's just one example. I'm sure there are many more that just come to me at first. I think that would bring down huge barriers for bringing it ultrasound into primary care. In terms of access for training, as you know, that there are multiple. Well, it's an area for research in terms of what is best and how to train. And we've all been working on our various ways to educate and support people who want to take up this skill. But there are no, more than 2 years ago, there are no more options available in the UK for people wanting to develop their skills, have mentorship, and have kind of expert clinical supervisors. And I'm happy for you to discuss that specifically, Pasquale, in terms of what people's options are. But certainly things are moving along, and in terms of accessing primary care in the UK, I think we're much better off than we were 2 years ago.
Which is nice to hear. And actually, if I may, I'd like to invite Camilla to comment. Obviously, she's got a wealth of experience in developing training and education in Denmark and also across Europe. And obviously, she's published extensively in this area. So I wanted to ask Camilla's opinion on this point of, access to training. How is it organized in Denmark? What are the barriers? Are the barriers that we have in the UK and elsewhere similar? Are they different? What is the solution from Danish sort of experience?
Yes, thank you, Pascal. So in many ways, the UK is standing where Denmark was like 10 years ago. At that point, we were only a few who had seen the light and had started using point of care ultrasound. And what we did was we started having just a small regional group, interest group for point of care ultrasound in general practice. In the beginning, we were only about 6 to 8 rural GPs in the group. And we started organizing appetizer courses to disseminate knowledge about point of care ultrasound, but also to motivate colleagues and to share knowledge and obviously also learn more ourselves. In 2015, the group connected to a research group at Aalborg University and started to join forces to coordinate efforts and initiatives so that the GPs could define which questions do we need answers to in terms of implementing ultrasound in general practice. And the research group could focus on answering those questions and providing data so that more people could be convinced that this was the future. And then in 2017, the group had grown quite a lot. There were a lot of GPs who were not only in the northern part of Denmark, but all over the country. And then we made a society, the Danish Ultrasound Society for General Practice. And we connected with the radiologists and started talking to them about what is sensible in terms of using ultrasound. And we also connected with the College of Danish General Practitioners and started to talk about how do we develop training programs, how do we develop quality assurance and guidelines for point of care ultrasound use in the future. Because our whole perspective here is that this is part of the future. Last year we did questionnaires, a survey for all young GPs, all young doctors who graduated from medical school, asking them about their thoughts on point of care ultrasound. And 80% of the young doctors expected that they would be using point of care ultrasound as a natural part of their tools in the future. And 60% of those who were not aiming to become general practitioners, they thought that point of care ultrasound could actually convince them that general practice could be a specialty for them in the future. So this has a lot of potential, and I think it is important that stakeholders know this and that they consider building on the skills that medical students learn through medical school in terms of ultrasound, and build on that in the specialty training for general practice as well. And through that develops the thing that Molly called for, the opportunities to develop competence over time and also have access to ultrasound equipment. So I think that is really important for the future. And it's coming whether or not the stakeholders want to look into this. Ultrasound is going to be part of the future, so they have a key opportunity right now to actually influence the use and help make it appropriate.
Thank you.
Yeah.
No. I didn't mean to interrupt. Carry on. So I want to try to grasp what you just said, which is very important. But if you haven't finished, please do.
I just wanted to ask the last thing that you mentioned, Pascal, is how do we do about training today in Denmark? So at this point, we have ultrasound training at medical school. We don't have it as part of the specialty training for general practice. We are working to convince the college that it should be part of the future. So it's postgraduate or CME courses for general practitioners at this point, and we provide courses on 3 levels. We have appetizer courses for those who have not yet bought a device, who are just contemplating whether or not this is something for them. Can I learn it? Can it be something that's useful in my practice? And then we have beginner courses, which are 3 months courses where they learn to use ultrasound and they implement ultrasound while we support them. And then we have the continuous courses, the level 2 courses, where they are more like area based. So that could, for instance, be a musculoskeletal ultrasound course. So that's what we have at this point in Denmark.
No, that's very kind, and thank you for sharing. So I guess just if I synthesize the key points that stemming from these comments, research inevitably is there. We need to build up the evidence so that we can actually demonstrate to society as a whole and the profession that what we're doing is not only effective, but is also, more importantly, safe, and it has a wider economic impact to society and the NHS, on this health services in general. Having a society of GPs with an interest in POCUS has been instrumental in Denmark to establish the conversation with the wider college of GPs as well as with the universities, and demonstrate that this modality of imaging in the hands of generalists, it really is important and adds value. Am I getting that right, Camilla? Yeah, that's what you was the synthesis. And then obviously in the UK, we are very lucky to have BIMAS with an interest in supporting us, Hazel. The question is, and you've got your hand up to ask questions. I'll invite you at this point to do so, please.
Thank you. Yeah, well, I just wanted to follow on from what Camilla was saying, in that how important it is to have your college's support and approval. And certainly, I think the situation for GPs in the UK at the moment is, as Camilla says, like it was for Danish GPs 10 years ago, but I also feel very much that it mirrors the journey that our emergency physicians have taken in this country, where 15, 20 years ago, there was a lot of suspicion around emergency physicians using ultrasound in their practice. There was a lot of concern, but nevertheless, they persevered, they practiced, they worked out the questions that could and couldn't be answered within the emergency department safely. And of course, look at them now. They have the Royal College of Emergency Medicine, RCEM, who's right on board with it. They have their own curriculum, ultrasound curriculum, basic and advanced, the core curriculum. They've reached a critical mass of emergency physicians who are now skilled in ultrasound, so that they can cascade that training down to other emergency physicians. So they've become self-supporting. And I think very much that over the years ahead, that's exactly the trajectory that UK GPs will follow. They'll reach a critical mass of skilled GPs who can then cascade that training to others. And of course, it's increasing, ultrasound use is increasing in our undergraduate medical courses, but we're still way behind mainland Europe. There's still very few medical undergraduate courses that have ultrasound as part of the curriculum, but it's growing.
Yeah. Thank you, Hazel. Thank you. I noticed a question in the WhatsApp group about longitudinal programs and mentorship. Let me just pick up that question and try to answer. There are opportunities in the UK as well as in Ireland and as well as elsewhere. Certainly, Primary Care POCUS does offer some similar support. Is that right, Lee? The Global Ultrasound Institute does it too. I don't know whether BIMAS has any active program or mentorship and longitudinal programs, Hazel, currently in the UK that I know of. But so answering the question that Greg was asking, yes, there are various providers out there, and reach out to any of us if you need to. I just wanted to just dwell a little bit on the society, Camilla, for a minute, because it seems to me that there was a pivotal moment when these enlightened GPs that wanted to do POCUS in Denmark decided to have a body, a professional body, to a standalone body, to be instrumental in having the conversation with the other institutions that existed there. Is that the case? Do you think that is somewhat a necessity?
I think it's in an important community, both in the beginning, but also when you get more GPs involved in this. In the beginning, it was a necessity in terms of developing the training programs, the guidelines, the common ground around ultrasound in general practice, a common understanding, but also communicating with the hospital specialists, telling them this is what we do and being united in what is it that we actually do. So where do we stop and where do you take over? And I think that was really important in the beginning. But then, and that was also important in terms of getting the college to accept us and getting the radiologists to accept us. And today, where we are actually a lot of GPs who use ultrasound, there are about 400 GPs in Denmark right now who uses ultrasound. And we are 3,500 GPs. And now you might think, why is not 2,000 or 2,500 GPs using ultrasound right now? And that is because there's no fee for using ultrasound. So it's still driven by a motivation coming from the GPs and not something that you can actually get a fee for performing. So today we have a Facebook group where we have 1,600 members, and we share cases and we share new knowledge in that forum. We have a Facebook, and we have an annual meeting, and we have courses and webinars during the year. So we are trying to create a community still. Although we are more established now, we still need to have the community to embrace the new ones and get them into the community and be part of it and share this common understanding.
Thank you for that, Camilla. Here's a challenge. We have 57,000 GPs in the UK. As far as Lee and I know, we've got less than 200 people that use some sort of POCUS in their practice. Is that correct? So that's the attrition ratio that we have to deal with. But anyway, this is a work in progress. Neither Lee nor myself nor anyone here in the panel or even in the audience will give up on this. So thank you, Camilla. This is very, very sort of illuminating, actually, because Lee and I and others, we've been exploring how can we have a gravitas within the existing learning landscape in the UK. Do we need to do it through existing organizations? Do we need to actually have a standalone society? And I think it's been very helpful to hear your experience and a track record of success that we may need to emulate somewhat, and we need to get together here in the UK and have this debate. Now, I've got the
Can I just add?
Sorry, go ahead. Go ahead.
So we do have regional groups still. So we have the society, but we also have regional groups who do small teaching sessions and have informal meetings with each other. So in all regions in Denmark, there are a regional group that is under the umbrella of the Danish Ultrasound Society for General Practice.
So effectively, you've got local networks, and so you've done it bottom up, which is
yes.
You and I and others, we've been discussing whether this needs to be a bottom up effort or top down, and reality will be probably both, and we need to work out the solution for the UK and Ireland. I just wanted to bring in one of our audience members that is a doctor in training, who he's just curious to know, and he's posting the question to the panel, to members of the panel regarding attitudes from others, partners and GPs, whether they have any negative experiences, as Molly was saying, that sometimes the seniors may have not been so receptive for the juniors to embrace this. And I'll bring the question to Lee and Beate, if that's okay. Beate, would you share with us what your journey was, and whether you have any negative experience by colleagues or others during your training or afterwards with regards to the use of POCUS in your practice?
Yeah, from other GPs that I've worked with, it's always been looked at as an asset, if anything, and I've often been referred patients from next door and within the practice, maybe, can you come and have a look at that? Can you scan this for me? And then they get interested and learn themselves. So I never had any negative comments from fellow GPs, I think. I think in the start, when I started, this is 12 years ago in Norway, we were probably also where Denmark was 10 years ago, or they're probably going ahead of us now, but in Norway. But still, I think where I got the most negative comments were probably sort of skepticism from hospital specialists who were saying, really, did you do that? Why would you have done that? That doesn't sound like a safe thing to do. A couple of times. You don't need many of those comments before it discourages you a little bit. You need sort of 10 times the amount of positive comments to make out for those. But I think they are coming less now, as most specialties have introduced more and more POCUS, and I think they realize this is here to stay. And radiologists are a different category altogether, and I don't think they feel this is a threat anymore. I think they've realized this is a different thing. It's not an imaging specialty we're trying to compete with at all. Something totally different. So I think it's getting better.
Thank you, Bjarte. Lee, would you like to comment? And then
Yeah,
Hazel.
of course. Mirroring what Bjarte's just said there, I think most GPs are supportive. They always ask the same questions, and they always think we want to be sonographers, and you have to kind of explain what it is, exactly what we're trying to achieve, what our remit of practice is, and then certainly from the colleagues that I've worked with, they're a little bit in awe of what can be done and achieved. And I'd like to think that, as a single GP, and certainly in the more competitive world of ARRS staff here in the UK, it puts you, in a very favourable position from an employee perspective. Moving on to secondary care, I've only had one person from radiology consultant pull me aside and just question why I was specifically doing a scan. And at that time, then I tried to make inroads into radiology to get them to support me with my journey and link up. And then when they came back and said, why exactly are you doing this? I was able to say, well, this is my remit of practice. This is my training. And, I said, I've been trying to make connections with you so that we can collaborate together. And actually I turned, that potential kind of little bit of friction into a positive experience, because I said to him, look, well, why don't I come and see what you're doing, and we can talk in person, and it ended up turning into a one-to-one training session with a consultant radiologist, which was fantastic. And he, after that, we completely knew what exactly we were trying to achieve. So it's, after that, moving on a bit further down the line now, I often see when I send patients to hospital, having done a POCUS scan, I often see my report in the medical record, which I print off and give to the patients. I often see that now in the CT request. They go, direct to CT. Which is quite scary in a way, is because, okay, I'm really positively influencing, decisions here in the A&E department. But, as that confidence and competence builds, that is the power that it has, and you can focus in straight to a specific problem. I'll give you an example. I've recently had a lady who presented to me, very early lady, quite frail, but happily got onto the bed with minimal pain in the right upper quadrant. I scanned that area, and I was like, because of bowel gas, I was pretty convinced actually that she either had a really thick gallbladder or an abscess there. And I said within limitations of my device and training, this lady, she's frail, but she's moving around well, but she's pyrexial. She went into A&E, went straight to scan with that because of her high temperature, and the same scan in A&E, and she had a perforated gallbladder. Whereas I think without the ultrasound at that point, given the way she was moving and a low-grade fever, I probably would have sent her home. She had some IV antibiotics and has made a full recovery. I suspect if we'd left her for another 24 hours, maybe 36 hours, you know, she could have come in significantly unwell. So I'd like to think I made a really positive difference there.
Thank you. Thank you for sharing. That's very. Hazel, would you like to add anything else, or I'd like to invite?
Yes, just briefly. Just briefly, yes, I agree with what Leah's just said, and it is about reaching out and making connections. And I do think in the UK, radiologists and sonographers are developing different attitudes. And I think the very fact that the Royal College of Radiologists published with us last year a guidance document supporting the POCUS community, recognising that they make a difference and offering help to them, I think that's a real step forward. And I would like to emphasise too that, yes, the imaging community with career sonographers, career radiologists, we don't feel threatened by the point of care ultrasound users anymore. I don't know that we ever did. I think we felt very much that there were a lot of people out there who were using ultrasound in a very careless and disrespectful way, and that they felt they needed no training whatsoever. Ultrasound is safe and dead easy, and who needs all this training business? Whereas now times have changed, and people in the audience here know that it's crucial to get the right training. Ultrasound is much more difficult than it looks, and they are reaching out to the imaging community for support. But just don't forget, you can reach out to sonographers as well, because they have plenty of experience and knowledge to impart to GPs. We have practice educators in many departments. We have ultrasound imaging academies now that have been set up and funded by NHS England, and they are also full of experienced ultrasound users. So it's not just the domain of radiologists. You may well make a good link with a friendly practice educator in your local department who will support you very well indeed. Thank you.
I agree with you entirely. And as a part of my team in the UK, we've got 3 very experienced sonographers that I'm delighted to work with. So the teams are clinicians with the skill. That is irrespective of your tribal background. So thank you, Hazel, for that. Thank you, Lee. Thank you, everyone. I'd like to invite Rachel. I don't want to put you on the spot, but since you are an early adopter in recent weeks working with us, and you are a doctor in training who has been sharing cases with me and been doing some remote monitoring and supporting and imaging quality control and all of that. Would you like to share your experience with the audience? And thank you for joining us.
Hello. Yes, thanks for having me. It's really nice to hear all these different experiences and in different countries across the world as well, to see how it works there. So thank you for answering our questions. So I recently got interested in ultrasound. Well, I don't know, I'd done a little bit before in A&E jobs, and I was always really impressed by the ED consultants that could do point of care ultrasound, and I thought they were really cool. So I've always had a bit of interest in it. And then I've recently undertook a global health fellowship where I've been working in Sierra Leone for 6 months. I actually just got back yesterday, so I'm fresh on UK soil. But in that setting, we only really had ultrasound. We sometimes had X-ray, but ultrasound was our main imaging modality. And I'd done a course, the famous course with Bromley Emergency before I came, which was really helpful. But I think it just got me thinking that I'm a GP trainee and how useful it would be if I could use some of these ultrasound skills in general practice. But I didn't really know if anybody was doing that within primary care in the UK. And then fortunately happened to get in contact with Pasquale, which was really helpful. And then he's connected me up to sort of the GUSI fellowship and taken it from there. And then, as you said, we've already just started, but sort of communicating remotely, which has worked well, of sending ultrasound scans across to him, where he was able to advise me on different techniques to get a better image, and also help with the scan interpretation, and how that would impact clinical decision making. So it worked very smoothly, actually, even with a difficult internet connection. And he was also able to ask other people for advice on like a slightly more complicated echo and things like that. So getting different opinions in, which made me feel more confident in my decision making. And it's very exciting. So.
Thank you, Rachel, and welcome back. We'll be in touch soon. I like to just bring a different dimension to the conversation. We've got 7 minutes left. And I'm looking at the chat as we speak on the WhatsApp group. Someone is asking about indemnity. I know, Lee, that you answer a little bit directly to the audience member. Would you like to make any comments about the ins and outs of where we stand in terms of indemnity and risk when it comes to using POCUS in general practice in the day-to-day journey, and perhaps any other of the panelists, if they can contribute to that point? That will be probably the last questions, unless you have any. I want to leave 3 minutes for closing remarks for all of you. So please go ahead, Lee.
Yeah, sure. So first of all, MPS are quite supportive if you want to perform ultrasound in the UK. So, you know, have a chat with your indemnity provider, as you should always do before taking on new skills and new responsibilities. You'll be quite reassured from that perspective. In terms of the litigation around point-of-care ultrasound here in the UK, I don't think there are any cases in law that have been brought yet. But if you look further afield, there is a recent study that was done in Canada, which I think was based in the emergency department. You'll find that actually I can't remember the exact numbers, but there are some medical legal cases brought about through erroneous interpretation of point-of-care ultrasound scans, but that is less than not performing point-of-care ultrasound when you have those skills to help someone on their journey, which is very interesting. So, and I think relatively speaking, the numbers were very small compared to the overall number of patients that we're seeing in the emergency departments. So, and that, you know, and that's in North America, where I like to think that litigious cases are much greater than here in the UK, but I couldn't quote any figures on that. So it is positively that's positively reassuring, I should hope. I would also like to just comment briefly on one of the other group members' chats, Ludmilla Morris, there in the group, that says, again, it's not a secret that lots of GP partners would view ultrasound done by GPs at surgery as an addition to another responsibility. And that's where I'd bring back in the POCUS mandate. So, you know, this is a skill that I would like GPs to have, or we would all like GPs to have within a consultation. So it's an addition. It's an additional skill within your normal day-to-day. We are not GP sonographers. There will always be a role for expert sonographers. You know, this is to be a skill to be used within consultation. So, you know, we're not trying to take over lists per se. We're trying to improve our diagnostic ability and our ability to treat our patients. And in essence, yes, it would reduce workload for secondary care, in truth, but you do that by improving the patient journey and, you know, reducing the health impact that their problem has on them. So indirectly, yes, it does come down, but it's about the patient journey and helping the patient.
That's right. I would add that is all about the specificity and sensitivity of your diagnosis, and it is within the responsibility of us as a clinicians, senior clinicians or junior clinicians, to do your utmost to answer the question, what is wrong with this patient? As I was presenting in my presentation, that is the framework of the consultation, that is irrespective of whether you are a emergency physician or cardiologist or so forth and so on. That applies to any doctor-patient relationship or clinician-patient relationship, so that we don't exclude our sonographers and other colleagues. Camilla, would you like to comment on the indemnity and give us your experience? And then I will go to Beate, and then finally I will give the final words to Hazel and Molly. Camilla, next, please.
Yes, I didn't think I understood.
indemnity, litigation, risk, complaints by use of POCUS, the harms that you refer in your presentation, which we use different terminology over here.
Yeah. So we did a review of 560 medical records of GPs who had been, of patients who had been exposed to a GP's point of care ultrasound examination. And we looked 6 months after the ultrasound examinations to see if there was any harms in the subsequent patient pathway. And what we found was that we found only one case where we actually saw that there was harm. And what we found was that a GP had examined a patient with shortness of breath, had looked at the lungs and found pleural effusion, had admitted the patient to the hospital where they did a chest X-ray, which has a lower sensitivity, and they didn't see this pleural effusion, and they sent the patient back home. The patient continuously had this problem with shortness of breath, and the GP again found this pleural effusion and sent the patient on to the hospital where they had a CT scan, which confirmed the pleural effusion, but said the end was that it was just something that was related to a pneumonia, or in the aftermath of a pneumonia. So the harm was this back and forth between hospital and primary care, and this cancer suspicion, which was actually a patient was sent on a fast track, a cancer suspicion onto the hospital, which was then not confirmed. So you can argue, was it actually harm? There was pleural effusion and the patient was sent on, but that was the only thing that we found. We did find some misdiagnosis, but the GP had actually performed well still. So they found something, couldn't really conclude what it was, and sent the patient on to a specialist to have the examinations repeated. So no harm was found in those cases.
Thank you, Camilla. I'm aware that we've got 3 minutes left. Beate, you've got 30 seconds. Hazel, you've got another 30, and Molly, another 30. Lee, if you want to interject as well. Beate, next, please.
I'm looking forward to going to bed now, so I'm not thinking fast enough anymore. I think my point I want to make is that I think we should look away from the question about can we do this or not. That's been proven. It's been dealt with. Now it's how can we do it? How can we do it safely? And how can we sort of make pathways for GPs to learn how to do it, and where can we get the money and all that? And that's where you need to get connected. You need to create a community, local groups, like Camilla said, national groups, get connected on Facebook, get connections across specialties, not the least, as you say, Hazel. Join BEMAs and go to their conferences and meet specialties across. I've done the same in Norway. I've been on the board in Norway. You can do things like that as well to create contacts. And that's when you start getting movement, and you have a drink with somebody on there and ideas go ahead, and that's when you get movement, I think. But don't doubt yourselves. You can do this, and it'll be good for yourself and the patient.
Thank you for joining us in the middle of the night. I do.
Good night.
So much, because
yeah, I've got 5 hours before my next patient now, so I'll go to bed.
Thank you, Beate. You're excused now. Hazel, would you like to make your final comments? You've got 30 seconds.
Absolutely. Yes, I agree with Beate. And how about some people contacting me if they want to be part of a GP special interest group affiliated with BEMAS. But we need college approval of GPs using ultrasound. We need a curriculum scoping their practice, which is coming, and we need national guidance, and all that will help protect them when it comes to indemnity.
Thank you, Hazel. Much appreciated. We hear that loud and clear, and we will pursue that. Molly, your final comments?
I don't have anything specific to add, apart from hopefully once all these things that Hazel has just outlined are sort of in place, then it'll pave the way for trainees to start getting
more involved with this too. I think it's exciting.
Thank you. Lee, any final point? We are just proceeding.
Yep, no final comments from me, but thank you very much, Pasquale, for organising this. You're an absolute gentleman, and I hope that everyone can understand now that this is very exciting for primary care.
Thank you. I just want to give the opportunity to our hosts, Kevin and Mena, to just say the final few words, because they were well instrumental in making sure that the technology and everything was organized. So I need to thank you on that as well. So if they want to just final comment. And thank you all of you for participating. Thank you to the audience. I'm sorry we cannot see you all, but it's been hopefully quite educational and enlightening for all of us, certainly for me. Kevin, Mena, final words?
Yes, just want to thank everyone again for being present, for joining this global community of POCUS passionate educators. I just want to quote, it's about the patient journey and helping your patient, and keeping our patients at the center of the conversation is to me the kind of it should be at the forefront of what we do and how we advocate and build community, our local communities, and that this is a journey. Thank you for sharing the stories from the emergency medicine community in the UK, from the GP community in Denmark, just being reminded that we are part of a journey, and that we are moving forward, and we are doing that together. So just so grateful for all of you and your time and your passion and your generosity and enthusiasm for this incredibly generative conversation. Thank you.
Kevin?
I think Matt summed it up really well. I'm just really appreciative to everyone here, and you know, we will be here as an organization and a community to be able to support. And I love what Bjarte said is that, you know, we can do this, because I think for a long time many of us didn't really believe that we were able to do it, that we didn't have permission to do it. But it's no longer a question of if, it is definitely just when and how. That's it. And so that's what we're really trying to do, is create that community and create those tools and create those experiences to really make sure that we're doing the best. We can do this the best possible way, and that's the safest for our patients. Just as Mena was saying, that the patients are at the center of this entire thing, and I think we all know here how great this is for patients, and they absolutely love it. And certainly Camila's research completely bears that out in a way that's, you know, really best demonstrated, I think, research about like the patient experience. And I hope there's going to be a lot more of that kind of research, because that is also going to help really drive POCUS as a movement throughout the House of Medicine and healthcare globally, because it's just so much better to wrap a service around a patient rather than sending a patient on a wild goose chase and having to see 4 or 5 different, you know, people in order to get a definitive answer. So as much as we can do this, the better. So we're just so proud to be a part of this, and thank you all for your time.
So on those notes, thank you very much to everyone that attended, everyone that contributed for your time. Thank you, Elizabeth, for helping me out over these so many weeks getting this done. And the webinar is recorded, so it'll be accessible. If you need a copy, let us know. We will make that to you, and you will hear more from us in the forthcoming weeks and months. Have a lovely evening. Have a lovely sleep, Bjarte.
Thank you. Good night.
Bye-bye, everyone.
Have a good summer.
Take care. Bye-bye.
All the best.